is Sheraz Daya. I'm from the United Kingdom. I am the medical director for a group of clinics called Centre for Sight. We're based in the south of England, in London, and in Sussex and Surrey. What I do fairly frequently is take out, replace lenses. So I'd take out multifocal lenses and in their place put in another multifocal lens. So for instance, taking out a zonal refractive lens and putting in a diffractive lens. And that can be quite challenging because if the lens has been in for about 5 to 7 years, the capsular bag is fibrosed around the lens, and it requires careful dissection, ensuring there's no damage to the remaining structures. Otherwise, we will not wind up not being able to do the intended procedure. So this is where the MST instruments are extremely useful in picking up the capsular bag, helping us get the viscoelastic under the bag, visco-dissecting the lens out, and also helping in a very delicate manner without harming the endothelium above and the posterior capsule below, being able to pick up the lens with just the right size instrument and prolapse the lens into the anterior chamber. There are a variety of instruments to make this very, very useful, including the cutters to cut the lens. They look very small and delicate, but they're actually quite powerful in enabling us to accomplish this too. The surgical skills are very important, but you can't do it without the tools of your trade. So, yeah, I hate to scale things at 1 to 10 because there's always room for improvement. So it's very hard to give anything a 10. All design is iterative. You use a device, you realize actually, a little change here or there can make a big difference, and that's instituted. So at this moment in time, if you ask me, do the MST instruments help me accomplish what I need to accomplish? Yes, they do. I have a few design ideas to make things better, which I hope to talk to the company about, and some newer instruments that I think will help us accomplish some of this complex surgery in the anterior segment too. I think the size of the instrument just needs to be appropriately sized to accomplish the job. And that means in the anterior segment it needs to be as small as possible. The finish has to be excellent. You can't have barbs on it. The ends have to oppose each other properly. That level of precision is very, very important. Otherwise it gets very frustrating for a surgeon trying to accomplish something if something's not quite correct. The angle of the instrument in terms of picking up tissue, all those little details make a difference, and it could be just a few millimeters, but it can make a big difference in terms of how we do surgery. Usually we try and dilate those patients as best as we can with mydriatic agents. However, there are times where it's just impossible. Sometimes I'll stretch the pupil to see if I'm going to get large enough to be able to do the job. But if failing that, then I'll use a Malyugin ring to expand the pupil, and that works very well. And I've used the ring in combination with a femtosecond laser to accomplish a good capsular rectus. It's a very satisfactory device, with great care and trying to be as delicate as possible, because it doesn't take much for things to go in an opposite direction. Those are cases where we have to take our time, we have to think on our feet because the plan could change. But generally speaking, the goal is to minimize lens movement and stabilize the lens. So that's where the MST capsular hooks are very useful. So once the capsulotomy is accomplished, the hooks stabilize the lens, and we try and get the lens out. I try and prolapse the lens after I've chopped it, prolapse those fragments into the anterior segment, so I'm not fooling around with zonules. Remove the lens, put a capsular tension ring in, and then put in the intraocular lens. If the zonules are really, really poor, then I have to consider another strategy. Am I going to sclerally fixate the lens for the long term, or am I going to use the bag and try and hook the bag into the scleral wall? That seems like an awful lot of work at times. Sometimes it's easier to transclerally fix the lens, either using sutures through Hoffman pockets or transclerally tunnel the haptics. I think it's like playing golf. You want to improve your game. We all enjoy doing cataract surgery, as we wouldn't be doing it, and we always reflect on perhaps what we did correct or not correct, and how can we improve our game. There's a lot of self-reflection at the end of the day.